Greetings to all. I, Dr. Priyal Yadav, welcome you all to today's Physio TV session. Today's session is about neuroplasticity in rehabilitation. For such an interesting topic, we have an extremely enthusiastic and a passionate speaker, Dr. Franny Nathani. Ma'am has done her UG from MGM Institute of Physiotherapy, Aurangabad. Her PG is done from BSPM's College of Physiotherapy in Nagpur. Currently, ma'am is pursuing her fellowship in pediatric and rehabilitation from London Academy of Sports and Health Sciences. Currently, she is also working as assistant professor at Sancheti Institute of College of Physiotherapy. We welcome you, ma'am. I hand over the session to you, ma'am. Thank you.
Hi, ma'am. Hi, Priya. Thank you for that warm welcome. And thank you to Physio TV for giving me this opportunity. I will just take a moment to share the screen.
Yes, ma'am, sure.
Is my screen visible, Priya?
Yes, ma'am. Yes, ma'am. It is visible.
All right. All right. Thank you. So today we are going to see neuroplasticity in rehabilitation. It is indeed one of my favorite topics. And in that, we are going to cover the history. That is the roots of neuroplasticity, where exactly it came into existence from. What is neuroplasticity? The mechanisms that underlie the recovery of function, the principles of neuroplasticity, and the treatment that is based on either the mechanism or the principles of neuroplasticity. So starting with the history, so Ramoni Cajal is a scientist who said in the early part of the 19th century that growth was not possible in neurons in the adult mammalian central nervous system. He also specified in his one of his papers that when development was complete, the growth and regeneration of axons and dendrites was lost. So this led to think of the brain as a rigid structure which was unmodifiable. So he said in the adult brain, nervous system pathways were fixed and unmodifiable. And that was the old dogma. That was the dogma that the old school of concept that the neuropathologists believed till 1960s. So they believe that there are a fixed number of neurons in the adult brain and they cannot be replaced when the cells die. But William James, in one of his studies, he had mentioned about the theory of neuroplasticity, and he said human brain is capable for continuous functional change. The first person to define the term neuroplasticity in 1948 was Jerzy Konarski, who used the term plasticity to describe it as permanent functional transformations. So basically, the neuroplasticity would be any changes with respect to the structure and function of the nervous system. The pioneer of neuroplasticity is considered to be Paul Bach-y-Rita for his various contribution and actually demonstrating neuroplasticity on actual cases. So we'll see a few of his cases further. He claimed that healthy regions of the brain can take over the functions of the injured part of the brain. And on the basis of his treatment, this was actually the basis of his treatment for people with various neurological disorders. So actually, I found this very interesting study. So the study was performed on people who had visual loss, and the subjects were made to sit on a reclined chair. There was one difference about this chair, that at the back side in the lumbar region of the chair, there were certain needles. The needles were sufficient enough to poke the skin, but not puncture the skin. So they were blunt. And so basically, the subjects were the one with vision loss, and they had cameras in their hands. And whatever the camera captures, the same image gets indented on their back using these needles. So for example, there's a telephone in front of him. So the camera captures the telephone, and the same telephonic picture that gets indented on his back, on the back region of the patient. So that was actually one case where there was a change of what do you say, the concept of cross modality came into existence, that is for compensation for the loss of visual input. It was now compensated using the tactile system. And the reason why the back region was taken into consideration was the hypersensitive area. So the back is considered to be a hypersensitive area, and that is why the needles were intending the image on the back. So moving ahead, so we'll first see what is plasticity. So as we all know, the plasticity of a structure is its ability to show any modification or change. So similarly, neuroplasticity is thus the ability to make adaptive changes related to the structure and function of the nervous system. So that means any changes in the structure or function of the nervous system will be called as neuroplasticity. Now, neuroplasticity is a continuum of changes. So in the initial period, in the short-term changes, what we see is changes in the synaptic efficiency. And when it persists, in the long run, we see actually the changes in the synaptic connections. So the number of synapses and their connections. So plasticity can occur at various levels, that is at the brain level, the network level, intercellular level, intracellular level, the biochemical and the genetic level, of which we are going to see the highlighted ones, that is at the network level and at the intercellular level. So network level is basically changes in patterns of neural activation and the cortical remapping, and intercellular level is at the level of synapse. So before we actually go to the changes that we see at the intercellular level, I would like to explain that there are two types of mechanisms that may underlie after neural injury. So one is direct, or also called as restorative approach, and the other one is indirect or compensatory mechanism. So what really happens in direct or the restorative mechanism is there is recovery of the injured tissue itself, or at the most the nearby neural tissues take over the identical neural tissue. So the recovery is possible either using the recovery of the injured structures or the nearby tissues. However, the compensatory approach, it will be a completely different neural circuits. They will be enabling the recovery of lost or impaired function. So to understand the concept of compensation and restoration, I will explain it using an example. So if there's a patient with hemiplegia who is right hand dominant, but secondary to hemiparesis of the right hand, if the patient is not able to use his right hand for certain activity, for example, let's consider feeding himself. So in that case, when we change the dominance of that person, that is, we train the person to eat using the left hand, so we are following the compensatory approach. That is, something else is compensating for the loss of function. For example, in this case, the left hand is compensating for the loss of right hand function. On contrary, when we train the right hand itself to complete the task of eating, we will be following the restorative approach. So before we see the intercellular changes that takes place at the the mechanism of neuroplasticity that takes place at the intercellular level. So this is a structure of a neuron, as we all can see, and this enlarged box on the left hand side that shows the site of synapse. So that this is neurotransmission taking place at the synapse level, where the blue bubbles represent the neurotransmitter, and this is the presynaptic cell and the receptors of the postsynaptic cell. So we will now see what are the changes that take place at the intercellular level. So at the intercellular level, we are going to see the formation and regeneration of synapses, which is also called as synaptogenesis. So we are going to see it under 4 headings: de-innervation, supersensitivity, unmasking of silent synapses, neural regeneration, which is also called as regenerative synaptogenesis, and collateral sprouting, that is reactive synaptogenesis. So starting with de-innervation supersensitivity, it occurs when the neurons show a loss of input from another brain region. So what basically happens is the postsynaptic membrane of a neuron that becomes hyperactive to whatever amount of neurotransmitter is being released. So let's consider a case of Parkinson's disease. So as we all know, in Parkinson's disease, there's loss of dopamine producing neurons in the substantia nigra of the basal ganglia. So what response do we get in order to compensate for the loss of neurotransmitter? So the postsynaptic neurons in the striatum, they will become hypersensitive to whatever amount of dopamine is being released from the substantia nigra. So this occurs through the postsynaptic cells forming more receptors to capture more dopamine. So this is the representation of it. So on the left hand side, if we see, this is the normal transmission, normal neurotransmission. But on the right hand, if we compare, so this is a case of Parkinson's disease where the yellow bubbles now represent dopamine. So there is reduced amount of dopamine, and what we see in return is the postsynaptic structures, the receptors, they become hyper excitable to whatever amount of dopamine is being released. But there's one thing about de-innervation supersensitivity. It occurs only when certain number of nerve fibers have been lost. So for example, when at least 90% of the nerve fibers in the substantia nigra that produce dopamine are lost, only then de-innervation sensitivity actually, supersensitivity comes into action. The next we are going to see is the unmasking of silent synapses. So what basically are silent synapses? There are various structural synapses which are present in many areas of the brain, but they may not be active due to competition with more dominant neurons. But when some experiential factors come into existence, so these silent synapses, they now come into play. So for example, in this image, if we consider the top image, so we see the purple structure that is synapsing normally, and the maroon ones, they are actually the ones that are the silent one, because the purple one is the one that is more dominant and there's no need. So the maroon structures, they are not synapsing and they will be rather called as silent synapses. On contrary, in the lower image, when there is some injury or some other experiential factors that come into existence, so along with the purple structure, we see all the maroon structures that are actively synapsing now. So basically, when the purple structure, when there will in any lesion, when there is a reduced amount of active synapses, that's when the silent synapses will come into action. In fact, the mechanism of certain drugs, such as amphetamines, is suspected to be through the recovery of function by facilitating the unmasking. Moving ahead, So now we are going to see two terms simultaneously. One is regenerative synaptogenesis, or which is also known as neural regeneration, or the second one is called as collateral sprouting. So in neural regeneration, what really happens is when the injured axon, the one on the top is the one that is the injured axon. And when it begins to sprout to synapse again, that time we are going to call it as regenerative synaptogenesis. In contrast, when the adjacent or the neighboring neuron, when it starts to synapse with the structure that was previously being synapsed with the injured neuron, that time we are going to call it as collateral sprouting. So injured neuron, when it begins to sprout, that is called as regenerative synaptogenesis. And when the neighboring structure that begins to synapse, it is called as reactive synaptogenesis. So we now move ahead. That was, so whatever we saw was the changes that we see at the intercellular level. And now we are going to see the changes that we see in the cortical maps after lesion and during recovery of function. So we are going to see it under two headings: remapping following peripheral lesions and remapping following central lesions. We start with remapping following peripheral lesions. So henceforth, I have tried to simplify things by putting as many researches or articles as possible. So we'll learn this concept using this research that was performed in the year 2002. So it was basically performed on the subjects whose upper limb was amputated. But in these subjects, when their face or upper limb was stimulated, that actually elicited phantom limb sensation, which suggests that the somatosensory representation of the face and the upper body had now expanded to occupy the arm and the hand area that was otherwise being not active. And the extent of shift in the cortical representation was correlated with the amount of phantom sensation. Moving ahead, we are now going to see the remapping following central lesions. So what we saw previously was following peripheral lesions, and what changes do we take place in the cortical representation following central lesions. So now this we are going to do under 4 headings. So first is reorganization of the affected hemisphere. So whatever will be the contribution from the affected hemisphere. Then contribution from the ipsilateral motor pathways, that is the uncrossed motor pathways for the recovery of function. What contribution do we get from the cerebellum? And then at last we see the cross modality plasticity. So we start with reorganization of the affected hemisphere during recovery. So I have put this image of motor and sensory homunculus, and that is to say when one part of the homunculus is the one that has been affected. So the adjacent structures around that lesion, they will become active and they will take over the function of that injured or the lost part. It can be explained using the Brodmann's areas. So for example, if primary motor area is the one that has got the lesion or the one that is affected, so in order to compensate for it, the premotor area and the supplementary motor area will now take over the function of the primary motor area. So that is the contribution from the same hemisphere. Now we are going to see the contribution of ipsilateral or uncrossed motor pathways to recovery of function. So when I explain that, so as we all know that not all the tracts, all the fibers of the tracts will cross. Some remain uncrossed and they supply the ipsilateral part of the body. So here I have put this image. I'll explain one study that was performed in the year 2002. So it was performed on patients with intractable epilepsy, and secondary to epilepsy, a part of their hemisphere was removed. So basically one whole hemisphere was removed, which is called as hemispherectomy. So for example, if the right hemisphere was removed, they were expecting the left side to get paralyzed. But surprisingly, after hemispherectomy, they did not get significant paralysis of the left side. And that may be because the right hemisphere, the one that had intractable epilepsy, that was abnormal since early childhood. So meanwhile, the contralateral hemisphere, that is the left hemisphere, had now started to take over the functions of the right hemisphere by supplying or innervating the same side of the body. So that is one research that was performed. The other that I have quoted was performed in the year 1992. So they used PET scans to examine the ipsilateral motor activity in patients who had capsular infarct, but they had eventually recovered from the resulting paresis. So now the subjects were asked to complete one task. So they were asked to touch their thumbs to various digits from both the unaffected side and the affected side. So they found that when the subjects were trying to touch the thumb to various hands on the unaffected side, there was increased excitability or activity in the contralateral hemisphere, which was absolutely normal. But in contrast to it, when the subjects tried to perform the same activity on the affected side, they observed that there was increased activity, or you can say the blood flow increased, not only in the contralateral hemisphere, but also in the ipsilateral hemisphere, which indicates that the ipsilateral pathways were also contributing to the control of the movement in presence of impairment of the right side of the hemisphere. We now see what is the contribution of cerebellum in the recovery of cortical injury. So as we all know that cerebellum plays an important role in motor learning. So it has been seen that the timing of cerebellar activation, it begins at 2 to 3 months after stroke and it persists for 6 months, which suggests that maybe the cerebellum contributes in recovery through motor learning. Its importance in motor learning. So the importance of cerebellar activation to motor recovery after lesion of the primary motor cortex with the cerebellar hemisphere opposite to the damaged corticospinal tract appears to have a more important role. The last thing that we are going to see is the cross-modality plasticity. So when the idea is when deprived of its usual input, that part of the cortex will now be normally be responsive to that input, will now be responsive to input from some other sensory modality. So if we consider braille readers for that matter, so if we consider braille readers, so they had expanded sensory and motor representation for their reading finger, which shows that the cortical representation that is dynamically modulated based on the experience and the learning. So basically, the tactile system now taking place or taking over the function of the visual system. Thank you.
So, ma'am, I would like to ask certain questions regarding today's topic. So, my first question is, as we discussed about the role of peripheral lesions and the central part. So, how exactly is the peripheral part included in cortical mapping?
Okay. So I think I explained it only with the research. Maybe that's why you did not understand it clearly. But basically, the cortical remapping that I meant to say, cortical remapping does not take place only when there is some central lesion. It also takes place when there is some peripheral lesion. For example, we saw this research where the upper limb was amputated, right? But when the trunk or the face, the upper trunk or the face of these subjects was stimulated, that elicited phantom limb sensations. So that elicited sensations of the part that does not exist. Right? So basically, the part of the arm and the hand area that was now taken over by the upper trunk and the face area. So the upper trunk and face area that got expanded to take over the functions of the arm and the hand area that was not being active because of the amputation.
Okay.
Do you want me to explain with the second research as well that we had quoted?
No, and I pretty much understood it. Yeah. Thank you, ma'am. And my second question is, as in central involvement, like when the central nervous system is involved, as we discussed about the role of cerebellum, the role of cerebellum is mainly for motor learning. So, is the role of cerebellum enhanced for motor learning when the cerebrum is affected some way during neuroplasticity, or how does it work exactly?
Okay, so the role, we know the cerebellum plays a very important role in relearning, right? So whenever there is whenever there is injury or some lesion, there has to be a lot of relearning taking place, because whatever the actions were learned, that gets lost, right? So there's a lot of relearning that has to take place. So now the cerebellum contributes to learn those movements again. That's how the cerebellum contributes for the neuroplasticity. It would not really take over the function of the cortex, but it will contribute by promoting the motor relearning more.
Okay. Yes.
Does this answer your question?
Yes, ma'am. They were really well explained questions, ma'am. Thank you. Thank you so much, ma'am. It was a very well explained session in such a short time. Thank you so much, ma'am.
Thank you.
Thank you to all our viewers. Thank you to Physio TV. Here we end the part 1 of neuroplasticity in rehabilitation. Thank you all.